Acute kidney injury, AKI, is a sudden decline in kidney function that results in the accumulation of waste products, electrolyte imbalances, and fluid overload. It is a common condition in hospitalized patients and is associated with increased mortality, longer hospital stays, and progression to chronic kidney disease if not recognized and managed early. Nurses play a crucial role in detecting early signs, preventing complications, and implementing evidence-based care. The kidneys are vital organs responsible for filtering blood, excreting waste, regulating electrolytes and fluid balance, producing erythropoietin for red blood cell production, and activating vitamin D for calcium metabolism. When kidney function drops suddenly, the body's internal environment becomes destabilized, affecting multiple systems. AKI is defined by a rise in serum creatinine, a reduction in urine output, or both. The KIGO, Kidney Disease, Improving Global Outcomes, guidelines define AKI as an increase in serum creatinine by greater than or equal to 0.3 mg/dl within 48 hours, or an increase in serum creatinine to greater than or equal to 1.5 times baseline within the last 7 days, or urine volume less than half a milliliter/kg/hour for 6 hours. AKI is broadly classified into 3 categories based on the underlying cause: pre-renal AKI, caused by reduced renal perfusion without direct damage to the kidneys. Common causes include hypovolemia, hypotension, sepsis, dehydration, and heart failure. Intrinsic, intrarenal, AKI, due to direct injury to the kidneys themselves. Causes include acute tubular necrosis, ATN, glomerulonephritis, and nephrotoxic drugs. Postrenal AKI, resulting from obstruction of urine flow due to conditions such as benign prostatic hyperplasia, BPH, ureteral stones, or tumors. Pathophysiologically, AKI results in a decline in glomerular filtration rate, GFR, leading to retention of nitrogenous wastes such as urea and creatinine, and disturbances in electrolyte and acid-base balance. Hyperkalemia, metabolic acidosis, hyponatremia, and fluid overload are common complications. In severe cases, AKI can progress to uremia, affecting the neurological and cardiovascular systems. Clinical signs and symptoms of AKI may be subtle in early stages. Nurses should assess for decreased urine output or anuria, fluid retention, edema, and weight gain, fatigue, confusion, or altered mental state, nausea, vomiting, or loss of appetite, shortness of breath due to pulmonary edema, elevated blood pressure, flank pain, or costovertebral angle tenderness. Nursing assessment is critical to detect AKI early. Accurate and timely measurement of intake and output, I&O, is essential. Nurses must monitor urine output hourly in at-risk patients, document fluid balance, and report any decrease promptly. Daily weight monitoring helps identify fluid retention. Serial vital signs, particularly blood pressure and heart rate, are crucial to assess perfusion status. Laboratory monitoring is equally important. Nurses should be aware of rising creatinine and urea levels, and trends in serum electrolytes. Hyperkalemia, defined as potassium greater than 5.5 millimoles/L, is a life-threatening emergency and requires immediate escalation. ECG monitoring may be necessary to detect peaked T waves or arrhythmias associated with elevated potassium levels. Preventing AKI is a primary goal. Nurses should be proactive in maintaining adequate hydration, especially before and after procedures involving contrast media. Nephrotoxic medications, such as NSAIDs, aminoglycosides, and certain chemotherapies, should be avoided or used cautiously. Nurses must advocate for renal-friendly medication adjustments and liaise with pharmacists and prescribers. Early intervention is key. When AKI is suspected, nurses initiate fluid resuscitation in cases of hypovolemia, as per medical orders, maintain accurate fluid charts, and escalate any deterioration. In cases of fluid overload, diuretics such as furosemide may be administered, but nurses must monitor for diuretic resistance and hypotension. Fluid balance management is a delicate process. Nurses must monitor for signs of dehydration, dry mucous membranes, tachycardia, hypotension, versus fluid overload, crackles in lungs, raised JVP, peripheral edema. Regular auscultation of breath sounds and daily weights are crucial to determine fluid status accurately. Urinary catheterization may be required for strict monitoring of urine output, but should only be done when clinically indicated. Aseptic technique must be used to prevent catheter-associated urinary tract infections, CAUTIs, which can worsen ACI. Nutrition is often affected in ACI due to nausea and catabolic stress. Nurses must monitor nutritional intake and liaise with dietitians for renal-safe nutritional plans, particularly low potassium, low sodium, and low protein diets when indicated. When ACI progresses or fails to respond to conservative measures, renal replacement therapy, RRT, such as hemodialysis or continuous renal replacement therapy, CRRT, may be required. Nurses caring for patients undergoing dialysis must be familiar with vascular access types, monitor for complications like hypotension, bleeding, or infection, and support emotional well-being. Patient education is a vital part of nursing care. Nurses must educate patients and families about avoiding nephrotoxic drugs like NSAIDs and contrast agents, maintaining good hydration, recognizing signs of fluid overload and when to seek medical attention, adherence to prescribed medications and dietary restrictions in patients with pre-existing chronic kidney disease, CKD. ACI can accelerate decline toward end-stage renal disease. Nurses should collaborate with nephrology teams to optimize long-term management, monitor for proteinuria, and assist with advanced care planning when appropriate. In aged care settings, ACI may present atypically. Confusion, lethargy, or a sudden change in function may be the only signs. Older adults are particularly vulnerable due to reduced renal reserve, comorbidities, polypharmacy, and increased susceptibility to dehydration. Nurses must monitor residents closely during illness, medication changes, or when fasting before procedures. In Australia, national standards support early identification and response to deterioration. The NSQHS Standard 9, recognizing and responding to acute deterioration, mandates that all health professionals, including nurses, are trained to detect and act on signs of clinical decline. Early warning score systems are often used in hospitals to standardize assessment. Interdisciplinary collaboration is key in ACI management. Nurses work with doctors, pharmacists, dietitians, renal nurses, and physiotherapists to provide holistic care. Physiotherapists can assist with mobilizing patients to reduce the risk of deconditioning and pressure injuries. Social workers can assist with support services, especially if ongoing dialysis or outpatient nephrology care is needed. Technology plays a growing role in ACI detection and prevention. Electronic health records may include automated alerts for rising creatinine levels, prompting early action. Nurses must remain updated with these tools and use them effectively. Documentation is a legal and clinical responsibility. Nurses must accurately document all assessments, interventions, patient responses, and communications with the healthcare team. Timely and clear documentation improves continuity of care and patient safety. In summary, acute kidney injury is a serious, yet often preventable condition. Nurses are essential in early detection, monitoring, and comprehensive management. By understanding risk factors, assessing fluid balance, interpreting lab results, advocating for safe medication use, and supporting patients through recovery, nurses help reduce complications, promote healing, and improve patient outcomes.